Thank you, Timo, very much for the kind invitation, and to Vitor and Timo for organizing and hosting such a fantastic meeting. I'll pause for a minute because I have a few disclosures, but perhaps my biggest disclosure is that I'm not a practicing physician. I'm not a neurointerventionalist. I'm just an engineer. The work I'm going to present was originally funded about 20 years ago by the National Institutes of Health, and then subsequently supported by Stryker Neurovascular and Medtronic Neurovascular. I think we got it wrong. We always talked about these flow diverters, and from a fluid mechanical standpoint, let's just review briefly what that is. Fluid mechanics through the vascular system is driven by a pressure gradient. It's the high pressure side of the heart to the low pressure side of the heart, and therefore you have blood flow going through this vascular system. But blood flow into an aneurysm is a sharply different phenomenon. It's just because there's a change in the boundary condition. There is no pressure gradient. If there is a pressure gradient, that means the aneurysm is bleeding. In a situation of an unruptured aneurysm, it's a momentum transfer. The fluid, the blood has inertia, and it has no boundary now, so it then transfers that energy into the aneurysm. And fundamentally, flow diverters take advantage of this difference in mechanism by redirecting or impeding that momentum while not altering the pressure drop. So that's very important, because in the brain, where you have very eloquent perforating vessels that you're covering with these devices, that pressure gradient is still preserved, so you still have flow to those branches. However, the momentum transfer into the aneurysm is disrupted, and that's fundamentally how this technology works. Now, I was party to what I think is a fallacy, which is really focusing on the flow diversion concept. We kept getting this grant declined, and so in 2001 we changed the title. It used to be called, endoluminal scaffolds that interrupt momentum transfer into aneurysms, and then we finally just said, okay, flow diverters to cure brain aneurysms. And I think that was the wrong word. Really, what happens when you cure an aneurysm is you're doing in situ tissue engineering. In other words, you're introducing a scaffold that grows a new artery over it, and it's that exclusion of the aneurysm that is the cure of that pathology. And this is not new. I mean, this was shown in the early 90s. This was work out of Freiburg by my colleague A.J. Waklu, who, and by the way, I don't think that they were really trying to do flow diversion. What they were trying to do, and A.J. is reluctant to admit it, but they were trying to do stent-assisted coil embolization, because coils were coming out, and they were very, it was going to be the new technology to treat brain aneurysms. And the problem with coils, of course, in a wide neck aneurysm is that they can herniate. And so they were trying to do a stent-assisted coil embolization with this particular Stryker stent, but every time they would navigate the catheter through this early stent, the stent would move. So they said, okay, let's just leave it there. We'll wait a month, bring it back after it's endothelialized, and then we can catheterize the aneurysm. But this is what they discovered. The aneurysm went away. And if you look at the pathology, or the histology, you can see that there's, in this particular device, a very dense vascular response, neointimal hyperplasia, reduction of the aneurysm completely fibroses and goes away. But this is the curative event. The curative event is growing that tissue boundary over the orifice or the neck of that aneurysm, thereby excluding it permanently from the circulation. And this was described again in that paper in 1994. So really what I'm proposing to you is not a new idea. In terms of fluid mechanics, we have exhaustively looked at how these devices work. And with these braided technologies, there's a really defined number of engineering parameters which you can turn the knobs. And I'll be honest with you, we've gotten there. In terms of the new technology that's coming out, it's all converging on a singular solution for the flow diversion effect by reducing the circulation inside of the aneurysm. And it really comes down to a porosity number, which is the amount of metal that you use. And that number is really well solidified. It's around 75%. And then we're converging now also on a concept of pore density, which is that you can have equal porosity as shown in these two diagrams, but by changing the diameter of the wires, and by the way, one of the limitations is a braider is holding the wire in tension, and the wire had to be thick enough to withstand that tension. So that was actually the limitation in the braiding technology. But now the technology has improved to the point where you can braid 12-micron wires. So these are really tiny wires. You do get to the point, we did a study years ago, I just want to mention don't get too excited about getting smaller and smaller. You can hit a point where the wires start to vibrate, and that actually does very bad things from the fluid mechanics standpoint. But anyways, in these two pictures, we have equal porosity, but different mesh densities or pore cell sizes. And here, this was some work done by Matthew Dubould looking at the fluid mechanics at the University of Ghent. In this particular patient-specific aneurysm model, tweaking these engineering parameters and looking for this particular case, what is the optimal device? And in this particular case, it was a 72 wire with a braid angle of 115 degrees. But the important thing is, do these engineering models in fluid mechanics, do they translate in vivo? And what I really want to share with you is what I think is going to be the next wave for flow diverter research, which is altering these mechanical constructs with the intention of growing cells over them. So really going back to tissue engineering. And let me show you one of our early experiments. I did this canine experiment about 5 years ago, and we implanted two different devices. And these devices are essentially the same thing. The only difference is we changed the braiding angle and the number of wires. So this is a 48-wire device with a porosity roughly of 70%. It's implanted on a sidewall aneurysm in a canine model. And I'm just showing you the vascular response at 7 days. So this is very early. And what we see here is the very beginning of the formation of the basement membrane, which is probably constructed mostly of fibrin. But there's large areas, both proximal and distal to the aneurysm, as well as over the aneurysm neck, that are still not covered at all by tissue. And then here, exact same dog. The aneurysm is on the other side with a different device. And here we see a complete early formation of the basement membrane at 7 days. I found this result to be really shocking. So we explored this in greater detail. By the way, don't use dogs. Bad things happen with flow diverters in dogs. They have an incredible range of motion of their neck, and because these devices are braided, they can actually start to migrate distally. So we changed our model, and we went into a rabbit model. We looked at 4 animals at each time point, 10, 20, 30, and 60 days. We ascribed 2 animals to receive a 72-wire device and 2 animals to receive this 48-wire device. Again, same porosity. Really, the only thing that we're changing is the pore density. And then we explanted these, and we did histology. So I'll skip that. Oh, basically the point of this slide is just to show you that we had a successful randomization scheme. There was no difference in the baseline characteristics. Here's a typical case where a flow diverter is implanted. We did leave it to the discretion. We do vaso-CT on every case, both in our animal lab as well as in the clinical lab. If we do see evidence of malapposition, we perform angioplasty, and then we document whether or not it was improved. And so here's the early data. So looking at just tissue, nothing, not the quality of that tissue, but just the tissue growth over the surface of the device as a function of time. We did see a slight difference. Remember, this is an observational study, very low powered, but we saw a small difference at 10 days, just confirming what we saw in the dog model, that with an increased pore density, we have an early, faster tissue response with more coverage using the device with a smaller or bigger pore density. And then we systematically looked from the neck of the aneurysm outward in a radial fashion, and we looked at the quality of the tissue, the endothelialization, using scanning electron microscopy. And we used a scale where 0 means there's absolutely no endothelial cells present, could be basement membrane, but no endothelial cells, all the way up to a 5, which is a fully endothelialized surface. And then we also looked at the gaps between the endothelial cells in order to come up with this in-between score 1, 2, 3, and 4. And I was actually surprised with such a small sample size at what we found, which is that the 48-wire device, these scores were significantly related, or almost significantly related, to the location. In other words, where along the stent you were, with the aneurysm actually not being well covered. It was from proximal and distal, the endothelialization, but it was spatially dependent. However, with the 72-wire device, we found that it was spatially independent, but rather a function of time. As time progressed, we had more endothelialization of the surface, which is fairly logical. But I hope what you take home from that particular part of it is that just by tweaking the mechanical design, we're not doing anything with surface chemistry. These are the same metals. They're treated the same way. We can change the way the tissue grows over the device. Another thing we wanted to do is look at how these things heal. It's been known since the late 90s that we have endothelial progenitor cells circulating through the vascular system. Cardiology has explored this dramatically with coronary stents, where they actually even have stents with antibodies on the surface of the stent to try to grab these progenitor cells in order to accelerate the process by which they're incorporated into the body. And we wanted to explore these progenitor cells, where they were on these flow diverters, when they were, and we used a very old technique with a streptavidin biotin complex using nanoparticles of gold, and we looked at this under scanning electron microscopy, and we found these things everywhere. We found them at 10 days, we found them at 60 days. We found less at 60 days, but we found them at 60 days. We found them over the entire surface of the device, at the level of the aneurysm neck, distal and proximal to the aneurysm. And here showing you on one of the struts a clump of cells. When you interrogate that under high magnification, you see these point hyperintensities. These are the gold particles, confirming that these progenitor cells are all along the surface of these stents. Why is this important? If you can understand the mechanisms of healing, you can then leverage those processes in order to make it happen more quickly and more robustly across all patients. I think flow diversion is a very exciting technology. I think it's curative by a tissue engineering process. I think that it's up to us in the engineering world to continue to look at not just mechanical design, but also really start to explore, and I'm going to give you another example of that, surface chemistry, potentially coatings, removing dependency on antiplatelet medication, and basically creating a more robust response to the device, and doing it so that there's not such a long latency period where the aneurysm is unprotected. Let me just give you a quick example of some recent work that we've done, investigating a commercially available, I don't know if it's commercially available in Canada and Europe, Shield technology is commercially available. It's a surface modification that basically departs a 3 nanometer thick modified phosphocholine, and it's been shown in various studies to be less thrombogenic. Now, this was explored 15 years ago in cardiology. There's a number of patients who have coronary stents with this kind of treatment, and it was never shown to really have a huge clinical benefit in coronary artery stenting. However, I would argue that these devices are dramatically different flow diverters, and moreover, the flow profile in the cerebrovascular system is completely different. Coronary flow is, of course, a diastolic waveform. In the brain, we have actually very high shear stresses, which lead more to platelet activation. So potentially this could be useful. We explored this using an existing coronary system, which is the optical coherence tomography in our rabbit model. Don't advocate, Patrick's going to talk to us about this in a minute, using this neurovascularly. The system really is built for coronary work. It has a very sharp transition zone and it's relatively large profile. So here's how we did it. We deployed the devices. Immediately after we deployed the devices, we took an optical coherence angiogram. This is after all of our animals, we did angioplasty to remove that as an independent variable. And here's showing a DSA that shows a great image with no thrombus formation, but when we interrogate this at 10 micron resolution, we can see, of course, a lot of thrombus formation on the surface of the device. And most concerningly, here at the origin of the vertebral artery, a lot of clot formation on the surface of the device. So what we did was we did 4 groups, 10 animals each, so this is a little bit better powered. We used a classic pipeline, we used the Shield version of the pipeline, and then we also, half of the animals were on dual antiplatelet therapy and the other half were not. And dual antiplatelet therapy consisted of oral administration of 10 mg per kg clopidogrel and 10 mg per kg of aspirin. Again, our randomization scheme was effective. There was no changes or differences in the baseline characteristics. Again, we had an extensive imaging protocol. We're actually still working on all this imaging data because every OCT acquisition is 540 images. Of course, VasoCT generates 512 images, so there's a lot of imaging performed. But importantly, OCT was done both after implant and immediately after angioplasty. And what we did was we just looked qualitatively. The problem with this particular OCT system is that flow diverters, we can't design a computer algorithm that can detect reliably and segment each strut of the flow diverter. So we're working on better OCT technology that gives it a much sharper profile so that we can segment that. So we did this qualitatively, and we just looked through the images, and we looked at clot formation along 4 areas of the vessel, distal to the aneurysm, proximal to the aneurysm, at the origin of side branches, and then distal to in the subclavian artery where there's a relatively low profile. So here's just a case. Proximal to the aneurysm, we have clot formation. Distal to the aneurysm, we have clot formation. At this side branch, we have clot. and distal in the subclavian area, we have a lot of clot formation. So this particular animal would receive a score of 4. And what we found, now if we break out the side branches, so now we have a score to 3, what we found was that dual antiplatelet therapy didn't matter as much as we had hoped. Actually, it was completely independent from the observations of clot formation along these vessels. What did matter was the shield technology, which dramatically reduced the scores of clot, the number of locations with clot formation, and very sharply decreased the amount of clot formation at the origin of side branches. This is one of my final slides. So what we found was that animals receiving dual antiplatelet therapy actually had a significant reduction in P2Y12 response units. However, it didn't seem to matter with the imaging of the clot formation on the surface of the device. However, the shield technology significantly reduced the clot formation, and especially at the origin of side branches. And there's the odds ratio there. We found that it was 1.72 times less likely to have clot formation with this particular technology. So what I hope to impart to you is a message that there's a lot of work to do, and it's really, I'm very optimistic that optimization of the mechanical design, which I think frankly is fairly close in terms of the flow diversion aspect, I think there's a lot of work still to do on the tissue engineering aspect, modifying the surface chemistry. And by the way, there's great work going on in Montreal at McGill University and at UCLA using bioreactors where they're growing cells in these patient-specific aneurysm models. And I think that might be a great way to advance this technology with tissue engineering as the highlight. So as most of you know who know me well, I do the minority of the work. I have a great team. I just go around the world and talk about it. But I really appreciate your attention, and thank you again for having me at this meeting.